Welcome back from the short break to the second set of this webinar. It's a great honor to introduce to you our medical doctor and PhD student here in the group, Rosendahl Madsen, who will be presenting the results of the Danish BCG trial in healthcare workers. Anne-Marie, the floor is yours.
Thank you, Christine. I'm happy to present to you the preliminary results from the Danish COVID-19 healthcare workers study. The objectives of this study was to reduce absenteeism among healthcare workers during the COVID-19 epidemic, and secondly, to reduce the number of healthcare workers who were infected with coronavirus, as well as the number of hospital admissions with the use of the non-specific effects of the BCG vaccine. This study was initiated in the beginning of the epidemic, and the reason for choosing absenteeism as main outcome was a lack of testing capacity at that time, and also we wanted to align with the Dutch trial in order to be able to compare data. This was a single-blinded RCT, and participants were healthcare workers from 9 Danish hospitals who volunteered to participate. Exclusion criteria were the known contraindications to BCG vaccine, as well as confirmed COVID-19. Participants were randomized 1-to-1 to a standard dose BCG or placebo in form of a saline injection. And participants were blinded to treatment, but investigator was not. We followed our participants for 6 months with weekly questionnaires about their health. We used the Bayesian and Cox regression models to analyze our data. And since our group recently reviewed possible effect modifiers of non-specific effects, these were also of interest to us. The effects may be gender dependent, and boosting might increase the effect so that revaccination is more effective than primary vaccination. Another aspect we were very interested in was possible interaction with other vaccines given during follow-up. And it has been shown before that the sequence in which vaccines are given is important for non-specific effects, and the last vaccine might determine the effect on the immune system. We therefore also included stratified analysis of these effect modifiers. We included 1,221 participants between May 2020 and January 2021, and we had finally 611 in the BCG group and 610 in the placebo group. Baseline characteristics were evenly distributed between the groups, and in all, 85% were female. In Denmark, we vaccinated at school entry with BCG until 1982, so most people above the age of 45 would have been vaccinated. In this cohort, we had 49% who had a scar from a previous BCG vaccination. Many of the participants also received other vaccines during follow-up, and as the inclusion took place over 9 months, some were included in the flu season, some were included before, and some after the COVID-19 vaccines became available. Follow-up adherence is significantly different between the groups. As we all know, it is difficult to achieve participant blinding with BCG, and there clearly was a bit more enthusiasm in the BCG group, resulting in a higher percentage of complete follow-up, 79% versus 70%. Today I will present the main study endpoint as well as the most important secondary endpoints. This is the main endpoint, unplanned absenteeism, and by that we mean absenteeism because of illness. We actually excluded absence because of stress or pregnancy-related problems or restitution periods after planned operations and such. We had anticipated a mean of 50 absent days per 1,000 work days, but in fact it was much lower. As we can see here, the mean number of days absent per 1,000 work days was 20. 20 in the BCG group and 17 in the placebo group. The difference was not quite significant, but there was a trend towards that BCG was associated with more absenteeism. When stratified by the effect modifiers, we saw no difference by gender, by age, or by BCG scar state, but the difference in absenteeism becomes more pronounced when looking at follow-up time after another vaccine was given. Here. If we look on the right-hand side, we see accumulated absenteeism according to time since inclusion here. Oops. And in the below curve, we see absenteeism related to calendar time. And here it also becomes clear that any difference in absenteeism is to be found in a period after December when it started to be given. Right, so moving on to the secondary outcomes, the first one is the incidence of verified COVID-19. There were a few cases of COVID-19 in this cohort, 43 cases in the BCG group versus 33 cases in the placebo group. BCG was actually associated with a higher incidence in the participant above 45 years and also in participants with a previous BCG scar. And as mentioned before, these are overlapping groups due to the Danish vaccination policy. We did not find any significant difference when looking at gender, follow-up adherence, or other vaccines. On the right-hand side, we can see incidence of COVID-19 in the according to calendar time, and the top curve is the participants who had a BCG scar at inclusion, and we clearly see the difference with a much higher incidence in the BCG group compared to the placebo group. And we see the incidence in participants who did not have a BCG scar at inclusion, and here we do not see any difference in the incidence between the randomization groups. We can also see here that in general, the incidence of COVID-19 increased around December. Looking at all-cause hospitalization, we can see that there are slightly fewer cases actually in the BCG group, 15 cases versus 18 cases in the placebo group. And though the numbers were small, we did actually see a strong interaction with BCG scar status, where we can see that the participants who had a BCG scar at inclusion and then were randomized to BCG had quite significant fewer hospitalizations compared to the placebo group. This is also illustrated in the above curve here, where we can see the previously BCG vaccinated participants and the incidence of hospital admission in the placebo group here and the BCG group here. When looking at the participants who did not have a BCG scar, we did see a tendency for more hospitalizations in the BCG group, though this was not significant. And finally, we are looking at the incidence of self-reported infection episodes. And it was clear that the participants randomized to BCG actually reported significantly more infection episodes than the ones in the placebo group, as we can see here. When looking at the stratified analysis, there was a slight tendency that this was more pronounced in females, in the ones above 45 years of age, and in the ones with complete follow-up. And furthermore, the higher incidence in the BCG group seems to be driven by a higher risk in this group in the period after another vaccine was given. And over here again, we see this according to time since inclusion and below the relation to calendar time. And this again indicates that any difference there would be in the incidence is to be found in the period after December, which corresponds to the period when other vaccines had been given. So, in summary, we did not see any effect of BCG on unplanned absenteeism. It did slightly increase the risk of self-reported illness. It did BCG, when looking at COVID-19 incidence, there was no difference overall, but BCG was associated with a twofold higher risk among people who had a previous BCG vaccination. There was no effect on incidence of hospitalization overall, but BCG was associated with a significantly lower risk of hospitalization for people who had previous BCG scar. BCG was also associated with a 16% higher incidence of infectious disease episodes, and the negative effect of BCG was actually stronger when looking at the time after another vaccine was given. So, we did not have any safety issues. There were no deaths in the cohort, and the incidence of serious adverse events was similar in the two groups, and none of the events were considered related to the trial vaccine. We did not see any serious adverse reactions to BCG. Finally, the take-home message: there was no strong overall effect of BCG on any of our outcomes. Though we did not see any effect on COVID-19 incidence overall, we did surprisingly find that BCG was associated with a twofold higher risk of COVID-19 among participants who had a scar from a previous BCG vaccination. And BCG did slightly increase the risk of self-reported illness, possibly because there were more symptoms in the BCG group, or possibly because there was an increased propensity to report symptoms in the BCG group, or very possibly both. What we found especially interesting was the possible effect of modification by BCG scar and interaction with other vaccines. It seems that BCG revaccination might increase the risk of COVID-19 and risk of infectious disease in general, but it might also protect against hospitalization and against more severe disease. Non-live vaccines given after BCG may negatively modify the effect. And finally, these findings underline the importance of distinguishing between primary vaccination and revaccination when assessing non-specific effects. And also the possible interaction between BCG and non-live vaccines leads to further discussion of the importance of sequence vaccines are given and the need for further exploration into this area. Finally, I would like to thank all the people who made this study possible. First of all, our project group, our collaborators at the participating hospitals, and also our local investigations. Thank you for listening.
You are muted, Christina.
I am sorry. Thank you so much, Anne-Marie, for your presentation. I think it was so clear and concise that there were no questions in the in the Q&A, at least. I don't know if there's anybody among the speakers or panelists who would like to unmute and ask any questions. I'm obviously biased with regards to this presentation.
I think Eva would like to ask a question.
Thank you.
Go ahead.
Yes. Thank you, Anne-Marie. These are really important results, and it's a very nice way to show them. Did you look, and I think you showed initially you didn't look, or you didn't have enough participants that got other vaccines, but those ones who were revaccinated with new vaccines, this was mainly mRNA vaccines, I guess, against COVID-19. or was there any other vaccine that was prevalent enough in that population that you could say something about it?
It was mainly influenza vaccines, and then mainly the COVID-19 vaccines, and almost all of our had the mRNA vaccines. Yeah, and in general, our participants, they actually accepted the vaccines they were eligible for. Yeah, but it depended. We had quite a long inclusion period, so that's why the numbers are a bit hard to judge. But other vaccines were very rare. I think we had 8 people who had another vaccine. That wasn't one of the before mentioned.
Do you see any differences between COVID vaccine and influenza vaccine?
We did actually. We're not quite done analyzing that, but the tendency towards the influenza vaccines giving more negative effects. Isn't that right, Christine?
Yeah, it's a great question, and something we are very curious to look more into. But it seems that this difference that Anna-Marie described in the BCG effect before and after other vaccines is particularly pronounced if that other vaccine is an influenza vaccine. So while it might be slightly beneficial to have BCG against all outcomes prior to other vaccines, then if you get an influenza vaccine that switches around, the priming with BCG may lead to more negative effects of the influenza vaccine, so to speak. But it's still early days.
Yeah, we are looking more into that, definitely.
But that's very important. Thank you.
And of course, something we hope that will be possible to study in other cohorts as well. Denise, I can see you are unmuted. Do you want to ask a question, or should we just get started with your presentation?
No, I just didn't want to make a mistake talking and everybody's waving at me. So. But
can I ask one small question, maybe? So, do you have any information, or maybe somebody else from the other trials, whether people, when they get the COVID-19 vaccine, for example, and if they are vaccinated with BCG, do they get more small side effects, fever, local pain, or whatever than the placebo vaccinated individuals?
We did not look into that, actually.
We neither, but I was curious because if the people, for example, react stronger, they get easier fever and so on, they might easier, let's say, be diagnosed because of that. But that if that is the case, it would be interesting to see whether they have indeed more side effects upon vaccination, because we know the COVID-19 vaccines are pretty inflammatory themselves. So,
yeah, I think we could look into that by just looking at the timing of the self-reported symptoms in relation to when they get the other vaccine. Because you have a point, Mihai, maybe it's in the first 5 days after the second vaccine that they actually accumulate. I don't think it looks like that from the curves, though. I do think they continue to go apart, not only, but it's definitely a great question, the timing of the self-reported symptoms and whether they could be just related to more strong responses to the subsequent vaccines and therefore stronger adverse events.
Oh, I'm thinking also in the future, it would be nice to look in the end at the serology and see also the asymptomatic infections, because you might think that, for example, the number of asymptomatic infections might be lower because people just react stronger. So it is easier then to have symptoms and get a diagnosis, go to be tested. Whereas maybe in the placebo group, people don't get that and they remain more asymptomatic.
And measure it all in the context, or look at the interferon response, that early interferon response.
Yes, and of course, what seems to emerge from all the studies, at least in what I can say, is that we don't really see, with maybe exceptions, some population, but we don't see really an effect on the number of infections. But the information would be important to see whether the severity, symptoms, and so on might be different.